Thank you. All right, everyone, I'll try to make this as painless as possible before we wrap up for the day. Before I start, I just want to remind everyone that, putting on my GI hat, this month is Colon Cancer Awareness Month, so remember to remind all your patients to get checked, and we have our little bands here. So we'll start with the pretest. First question is, what is one indication for liver transplantation? You've got cirrhosis, model for end-stage liver disease score less than 15, model for end-stage liver disease score greater than 15, or metastatic liver cancer. So respond to your text. So everyone had a chance to respond. We'll move on to the next question. All right, so then what is one indication for heart transplant? First is congestive heart failure. Second is New York Heart Association class 3 or 4 heart failure. Third is cardiomegaly, and fourth is myocardial infarction. Is anyone responding? Is it okay? I got some responses. Okay. We'll move on to next question. What is the strongest predictor of alcohol recidivism post-transplant? So first is prior negative social or health consequences from drinking. 2 is duration of sobriety. 3 is the type of alcohol they drink, whether it's beer, wine, etc. Or 4 is friends that drink. All right, and we'll move on to the last question, which is what determines priority for liver transplantation? Is it social status? Is it wealth? Is it duration of time on the waiting list? Or is it severity of liver disease? See how many cynics are in the audience. And then finally, what is one way of getting a transplant sooner? A, you pay someone off. B, agree to be a donor yourself. C, argue with your transplant surgeon. Or D, multi-listing at centers with better organ availability. We've got maybe no cynics, but some contrarians. All right, so let's see. All right, so I'm going to talk about how do I get my patient a transplant. You're seeing your patient in clinic, you think, one of these need a transplant. How do I make that happen? How do I get that done? So we'll talk about candidacy for various solid organ transplantation, and then the process of how you go about getting them on the list and getting them a transplant. Hopefully by the end of this you can recognize the basic indications and contraindications for liver, heart, and kidney transplant. I won't talk much about lung just because we don't do lung transplant at Loma Linda, but I can answer any questions about it if you have any. And then I hope you'll become familiar with the general structure and principles underlying organ allocation in the U.S. So the outline is as such. We'll talk about an approach to evaluating a potential candidate for a transplant. 2 is the referral process. 3 is how they actually get on the list. 4 is organ allocation, what determines who gets an organ first. And then 5 is follow-up, including when they're back with you in your clinic after they have been sent back from the transplant center. First, just some basic principles of rationing. So there's a couple different principles that come into play here when you talk about allocating scarce societal resources. One is equity, treating all people the same. Aristotle said that justice is treating like alike and differently. Utility is maximizing the benefit of a scarce societal resource. Urgency is, well, we have a moral obligation to treat the sickest first. That's been a principle of medicine ever since the days of triage in the battlefield. Then finally, social work, social worth. How is this transplant going to affect not only the patient, but the society in general? The general consensus in the field of transplantation has come to be that we try to target survival benefit. So this is a combination of urgency plus utility, combined with an equitable process. So John Rawls said, we may disagree on the criteria by which we are deciding to allocate scarce resources, but at the very least we should have a transparent and equitable process. So when I see a potential transplant candidate in clinic or in the hospital, I try to just answer 3 questions. And of course, this is in addition to all the other stuff I have to do in that 20-minute, 15-minute visit, dealing with all their symptoms and their preventative care. I try to answer, does this patient need a transplant? Number 1. Number 2, are there any medical contraindications? And then 3, are there any psychosocial contraindications? So for liver, the main approach to determining if a patient needs a transplant is by calculating their model for end-stage liver disease score, or MELD score. This is a combination of bilirubin, INR, creatinine, and now sodium as well. And you can calculate yourself easily by going on the OPTN website. If you just Google OPTN MELD calculator. There's other calculators such as MedCalc, et cetera. Those are sometimes wrong, not usually, but sometimes. So I recommend using the OPTN website. And I have that on my phone. I have an active web page that I just go on and when I've seen a patient in clinic, I plug in the numbers, calculate the MELD score. And that determines how sick they are from a liver standpoint. It's a very strong predictor of their likelihood of dying from liver failure in the next 3 months. Interestingly, though, it's not really determinant of how likely they are to survive a liver transplant. So when you go from a MELD score of 6, which is the lowest and normal, essentially that would be my MELD score, I hope, to 40, which is the highest, that's where it caps off, the risk of dying from liver disease varies more than 100-fold. But the risk of dying as from complications of a liver transplant varies less than 3-fold. So what that means is that MELD is actually a good predictor of survival benefit of transplant. And so that's shown by this seminal paper, which showed that this is the hazard ratio for death with transplant versus without transplant. And for patients with MELD scores less than 15, they actually have a higher risk of dying. So patients with a low MELD score, they'll say, well, why don't you just get me transplanted sooner while I can still tolerate it and do well? And I say, I understand where you're coming from, and that makes sense, but the problem is you're just at very low risk of dying from your liver failure. And so that is usually something they can understand. And I say, your risk of dying of complications of the transplant is around 10% in the first year. And your risk of dying from liver failure is much less than that. Whereas if their MELD score is greater than 15, particularly when it gets up into the 20s, their risk of dying of liver failure becomes quite high in the near future. In fact, when it gets to be 40, almost all of those patients will die of liver failure in the next 3 months. So these are the ones that anyone with a MELD score at 20 and above, we definitely have to get them worked up and get them on the transplant list. There are other criteria that are not driven by the MELD score. So there are other predictors of death from liver disease that MELD does not determine. And one of those things is liver cancer, which is very common in patients with underlying liver disease and cirrhosis. And there's something called the Milan criteria. So patients with 1 tumor less than 5 centimeters or 2 to 3 tumors less than 3 centimeters without vascular invasion or extrahepatic spread can get exception points for transplant. So these patients will benefit from transplant. It can be curative of their cancer. When there's larger tumor or the tumor is spread outside the liver, unfortunately, their risk of recurrence after transplant is high. And so that's why those patients cannot receive a transplant, because if we transplant them, but the tumor just comes right back, we haven't done them any favors. Now moving on to kidney. So the indications for kidney transplant are history of ESRD on dialysis or CKD with an eGFR less than 20. If they're a candidate for another organ, then their eGFR has to be less than 30. Pancreas is, the indication is insulin-dependent diabetes. This is most commonly done in combination with kidney transplant, so kidney pancreas. And then heart, the indications are severe heart failure, so not just congestive heart failure, but severe heart failure, New York Heart Association class 3 or 4, despite maximal medical therapy. Restrictive or hypertrophic cardiomyopathy with New York Heart Association class 3 or 4 symptoms. Refractory angina pectoris with documented cardiac ischemia. Recurrent or refractory VT, or complex congenital heart disease with ventricular failure, or rarely unresectable cardiac tumors. So these are the general indications. These are the things that make you say, okay, I think my patient needs a transplant. Their liver, their MELD score is greater than 15, or they have liver cancer within the Milan criteria. For heart, they generally have bad heart failure, or bad VT, or bad angina. For kidney, mostly it's ESRD, or just about to start dialysis. And pancreas, insulin-dependent diabetes. So what are the medical contraindications? What would be a reason why they, despite needing a transplant from an urgency standpoint, they can't get one because although they're at risk of dying of organ failure, they're also at high risk of dying with a transplant. So that delta, that survival benefit would be low. So for liver and kidney, anyone with advanced cardiopulmonary disease, so really anyone with a decreased ejection fraction, so heart failure with reduced EF, or severe pulmonary disease with an FEV1 less than 1. Those are contraindications to liver and kidney transplant. Uncontrolled HIV is a contraindication. Controlled HIV is not. We transplant patients regularly who have HIV if it's well controlled. If they don't have an AIDS-defining illness, if their CD4 count is greater than 200, and then ideally if their viral load is fully suppressed. For cancer, here's where I get to play general internist, because it depends totally on the type of cancer. So you can't just say, oh, well, any cancer, they have to be cancer-free for 2 years, because we know that for breast cancer, for example, it's a very long recurrence curve, right? 2 years is not that much different in terms of risk versus 3 years. But some other cancers, once you're at the 2-year mark of remission, then you're in really good shape. So it all depends on their risk of recurrence. We look at the stage, the type of cancer. We try to go online and find various calculated tools, or we call the oncologist and we say, can you please just tell us what is their chance of recurrence? And if it's less than 10%, then generally we proceed with transplant. There are some tumors that are particularly immunologically sensitive where we have to be a little bit more cautious because we're going to be putting them on immunosuppression. Melanoma would be a perfect example of that. So we've addressed who needs a transplant, medical contraindications to transplant. Now, moving on to psychosocial. This is the most difficult because it's the most subjective. Really what we're trying to get at is, will this patient be a responsible steward of a scarce societal resource? We are not trying to judge their social worth. We're not trying to say, you're worth more to society than you, and therefore you're going to get a transplant. We're not trying to play God. We're just trying to say, there's a limited supply of organs. We need to put these organs into people that are going to take good care of them because otherwise it's a waste. We could have used that organ that would have maximized many years of survival for someone who actually takes good care of it. So we look at things like substance abuse and all the details surrounding that I'll get into. We look at compliance, and not like, oh, they're labeled non-compliant on the chart, but we really have to get to know them and learn. Once we engage in mutual goal setting and motivational interviewing, and they agree that this is their goal, and therefore this is what we have to do to achieve that, do they follow through? I tell people sometimes if they don't quite get it and they're arguing, I tell other doctors, I try to say that transplant's one of the last bastions of paternalism. And to patients, I often say, look, unfortunately, the way it is that if you want a transplant, we say jump, you got to say how high. Unfortunately, that's what you just have to do to get a transplant. And then we look at their social support. The Lone Ranger, unfortunately, is not a good transplant candidate because when around the time they're getting their transplant, there's a lot of needs. They need someone to drive them to the hospital, someone to drive them to appointments, someone to track their medications, make sure they take them on time, someone to follow up to make sure they get their labs drawn. And so generally they need to have at least one strong and preferably two social support people that are really willing to commit and help shepherd the patient all along this journey. So going back to substance abuse, alcoholic liver disease is kind of the elephant in the room. And when transplant was beginning, remember transplant's not that old. Many of you may remember a time when transplant was considered experimental. And then with the introduction of cyclosporin and then tacrolimus in the 80s, then it kind of was a boom of transplant occurring in the 90s. And early on, patients were getting transplant. They were going right back to drinking. And so we soon learned that we had to select out which patients with alcoholic liver disease are going to be good stewards of that scarce societal resource by trying to predict who is going to be likely to stay abstinent and who is going to have recidivism. And when I say recidivism, the substance abuse literature divides this into slips, so one-time drinking. Slips are common. Unfortunately, post-transplant, almost half of patients with alcoholic liver disease have at least one slip. But it's really that return to serious drinking that's harmful. That's generally around 5% or less, and we want to keep it as low as possible. So there's been this traditional 6-month rule with the duration of sobriety being a predictor of risk of recidivism. But it's not the best, and it's not, when you look at the area under the ROC curve for that 6-month rule, if this was a diagnostic test, you would not be using it. It's very low sensitivity and specificity. And so we have to look at other things. And those things are prior negative health or social consequences. That's the strongest predictor. So if a patient was drinking heavily, they had a variceal bleed, and then they kept drinking, that's a patient that's at high risk for recidivism. Or they had a DUI and they kept drinking. Or they had a divorce and because of their alcoholism and they kept drinking. So those are patients that we're very cautious about. The patient who was a 6-pack a day guy but still working and taking care of his family and or her, either way, and really never had any negative health or social consequences, and then all of a sudden gets sick with liver disease and said, oh, that's it, I'm done, never touching that again. You want me to go AA? Sure, I'll do it twice a day. I'll do whatever you want. That's the type of person that we are looking for. So going from criteria, we're now moving on to process. So the country is divided from a transplant standpoint. So the UNOS, United Network for Organ Sharing, is a private company out of Richmond, Virginia, that's been under contract to the Department of Health and Human Services to operate the OPTN since the 70s. The OPTN stands for the Organ Procurement and Transplantation Network. So they're the ones that operate the organ procurement and allocation system in this country. And from an organ distribution and allocation standpoint, the country is divided into regions. We're in Region 5. And then it's further divided into organ donation service areas. Each donation service area is covered by one organ procurement organization. These are private, non-for-profit companies that are under contract to the Department of Health and Human Services to be the organ procurement entities. So they develop relationships with all the hospitals in their area, and they work to try to maximize organ donation and recovery. There are some laws that support that. There's a required notification law, so each hospital is required to notify their local OPO when they have someone who is brain dead. And there's a required request law that the OPO is required to ask the family for consent to donate. But the devil's in the details, and it turns out there's variation across the country in how well these OPOs do at actually getting the organs from their area. And that's one of the things that drives the strong variation in organ availability. So that's on the supply side. The demand side, there's also variability in referral rates for organ transplantation. So as a result of that, you have geographic variability in organ availability. Unfortunately, in Region 5, we live in one of the worst areas for organ availability in the country. So California and New York in particular are the worst in the country for just not enough organs to go around. The best is Southeast. And for some reason, there's fewer people referred for organ transplantation there, and there happen to be a lot of donors. And so when people say, how can I get a transplant sooner? Generally, I tell them to go to the Southeast or the Midwest as well, is a little bit better. So going back, when you're talking about referral, you see your patient in clinic, you think, I think they might need a transplant. It doesn't seem to have any overt medical or psychosocial contraindications that I can see based on what I heard from Dr. Volk. So I'm going to refer them. Well, how do you decide where to refer them? In some areas, there's really no choice. There's, for example, if you live in Nevada, there's actually no liver transplant program in Nevada, so that's why we have an outreach clinic there. But in Southern California, we're blessed with quite a few programs to choose from. As a general principle, you don't want to send a patient further away than you have to unless you have a good reason. It's a lot of work for patients and their families. It's a burden on them. Lots of visits back and forth, lots of driving, like the gas money. We may not think about gas money as being a big deal, but for a lot of patients, gas money is. But you still want to send them to where they're going to get good care. And fortunately, the outcomes are publicly available on the SRTR, or there's another website for OPTN. If you just Google OPTN, liver transplant, or heart transplant center outcomes, and you can find it. So it's all publicly available, and there's a 1-year patient survival that's observed, and then there's predicted. So they adjust for how sick the patients are, and you just want to see that the observed matches the predicted. If the observed is statistically significantly lower than the predicted, then you know that there's probably a quality problem there, and you might want to consider sending the patient to the next further center away. So you refer them, they get seen. If the specialist, the cardiologist, the transplant nephrologist, the transplant hepatologist decides that, yeah, I think they may need a transplant, they may be a good candidate, they're entered into workup, and they undergo a series of tests that takes anywhere from 1 week if they're in the hospital and they're really sick and we're doing everything bam, 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 or 3 months if they're outpatient and they're just taking their time. They're doing these tests in between their work and their other obligations. And so mainly it's making sure they don't have any cancer that's not controlled, any severe cardiopulmonary disease, et cetera. And then they're discussed in a transplant selection committee. These were always fairly opaque bodies that, a bunch of doctors in a closed room deciding life and death. And it's true, it's to some extent still like that. I did a study where I had a medical anthropologist observe and record these meetings throughout the country. And so if you're interested, that's some further reading. If the patient is decided to be a candidate, then they're placed on the transplant list, and they're given a formal letter that says, you are now on the transplant list. It's amazing to me how many patients think that they're on the list just because they have an appointment to see me for the first time in a couple weeks. So that's, the primary care doctor or non-transplant centers can't put a patient on the list. It has to be a transplant center. And so, tell patients, don't worry, when you're on the list, you'll get a formal letter that makes it very clear. And when we take them off the list, we're required to send them a formal notification. So then they're on the list. So what determines who gets an organ first? Well, it varies by organ. So for liver, the first is status 1, those with acute liver failure. Those are patients that have no prior existing liver disease. They develop acute hepatitis B or Tylenol toxicity, and they come into the hospital, they're very sick, cerebral edema. So those are priority status 1. Then it goes by their MELD score. And it goes first, those with the highest MELD in the local area, then in the region, and then out nationally. And so bottom line is that here in California, you got to get a MELD score generally, most of the time, into the 30s to get a transplant. Occasionally we get lucky and we get a good organ for someone, transplant them when their MELD is in the 20s, but most of the time it's in the 30s. So they're pretty sick by the time they get a transplant. For kidney, it's primarily time on dialysis, along with blood type. Higher priority is given to pediatric candidates, prior living donors, more difficult to match patients, those who are highly sensitized, and those who are dual organ candidates. Bottom line is that depending on their blood type and a few other factors, it generally takes about 6 to 10 years on dialysis before they get a kidney transplant in California. This issue of highly sensitized, I should mention that for most organs, we have to match them match the patient to the donor not only by the blood type, but also by HLA. But liver actually is kind of a relatively immune privileged organ to the extent that if we do a liver and kidney transplant together, as long as we put in the liver first, we actually don't have to HLA match the kidney. It's kind of a fascinating thing. Priority on the waiting list for heart, so status 1A on inotropes, LVAD, Swan-Ganz catheter, those considered very short time left to live without a transplant. 1B is on inotropes in or out of the hospital, and then status 2 is at home waiting. So this waiting, I mentioned that transplant's the last bastion of paternalism, and it's kind of ironic because we spend all this time telling patients that you just have to do whatever we say, and we say jump, you say how high, and just do what we tell you. And then we give them a transplant, and we say, okay, you're now responsible steward of a scarce societal resource. It's up to you to take good care of this. You need to be proactive and take responsibility. So it's a little bit contradictory. And so what we've done at Loma Linda is we've developed something called a prehab program, rehabilitation. So rather than doing the transplant and try to rehabilitate them afterwards, we try to prehabilitate them. We focus on their functional ability, their psychosocial health, their spiritual health. So it's a whole person care thing that we have in our transplant center. Options for quicker transplant, everyone always asks about. So one is, there's always exceptions to every rule, and so for every organ, there are exceptions where this patient may not fit the normal box, and so we may think that they have a higher risk of mortality. It's not judged by the normal factors. And so we can write an appeal to the regional review board. So we all take turns being on this regional review board, and so we can write appeal, Mr. So-and-so, I really want to advocate for him. I think he needs a transplant because this, that, and the other. And if we are convincing enough, then sometimes we get awarded extra points for the patient. So we have to be strong patient advocates. And I've had referring physicians, primary care physicians, call me and say, I think this patient really needs a transplant because of this and this. What can you do? And sometimes they'll bring up points that I didn't realize about the patient and say, well, great, thank you so much for calling me. Let me submit an appeal to the regional review board, and sometimes it's successful. Multi-listing, patients are allowed to multi-list, they'll go get listed at multiple different centers. That takes a lot of time and money, and their insurance has to approve it, so all kinds of factors go into play. Unfortunately, it's only generally the relatively wealthier patients that can do this. But I tell people, you're wasting your time if you're multi-listing down the street, because the organ availability is no different. If you really want to multi-list, go to some place like the southeastern US where there's better organ availability. Living donor for liver, to some extent for kidney is a great option. So we really try to push patients to try to find living donors for kidney. Liver is a little bit more controversial. We don't currently do a living donor liver transplant at Loma Linda. We're considering starting it in the future, but we take it very seriously because the risk to the donor is substantial. So the risk of dying from donating a kidney is 1 in 10,000. So that's like the same risk as driving in California freeways, right? I mean, that's very safe. The risk of dying if you donate part of your liver is 1 in 100. So 100-fold higher risk. So that's why living donor liver transplant is done much less commonly than kidney transplant. And then finally, a topic that I've published a lot on is accepting a marginal organ. So there's a little over 6,000 liver transplants a year in the US. Well, there's a lot more deaths in the US than 6,000. So what happened to all those other people that died? Well, it turns out that most of those organs are not used because of concerns about quality. So for example, people that die cardiac death, usually the organ is not as good because there's warm ischemia time before the organ can be procured. So donation after cardiac death is done sometimes for liver, a little bit more for kidney, but still represents a very small fraction of the overall deceased donors. Most of them are brain dead donors. So there's also various other things that come into play in terms of organ quality. So there's two types of donor-specific risks. One is risk of disease transmission. So many people don't actually realize that you can get a disease from the donor with a transplant. You can get an infectious disease. You can get HIV, hepatitis C, hepatitis B, et cetera. You can get cancer. You can get various types of cancer from the donor. So each time we get an offer, we review the medical history carefully, and we have to figure out, okay, this donor had a history of this type of cancer. What's the risk of transmission? Counsel the patient. Say, well, they had a glioblastoma multiforme. That's almost never associated with transmission, but it could happen. Or they have a renal cell cancer in the contralateral kidney. That's almost zero risk. We think you should take it. But they have metastatic melanoma, forget it. We decline that offer. For infectious transmission, it depends on the type of risk factor. We've recently started a protocol where we actually knowingly use hepatitis C positive livers and soon to start kidneys as well for patients who don't have hepatitis C. And you might say, well, that's crazy. You're actually giving people hepatitis C? Well, it turns out that now hepatitis C has gotten so easy to treat. In the liver transplant program, our post-transplant hep C cure rate has been 100%. And the medications are safe and effective. So if it means decreasing the patient's chance of dying of liver failure, then it's a risk worth taking. The second type of risk is the risk of graft failure, and that depends on the donor age, how much fat is in the organ, particularly in the liver, various other medical comorbidities, et cetera. So moving on to follow-up. So the patient got their transplant. It was successful, and they're followed very closely by the transplant center for the first year. But then after that, they're mostly released back to their local physicians. The transplant center may see them once a year, maybe twice a year. And here's where I want to just put in a plug for, because of all the medications we give them, the tacrolimus increases the risk of diabetes, hypertension. They were on steroids for a while. All these patients have very high cardiovascular risks. And I often see that their primary care doctors are concerned about various things, statins, other things, and say, oh, they're a transplant patient. I'm sure the transplant center is taking care of that. Not necessarily, and so we have to make sure we have good communication and co-management. Statins are safe in all liver transplant patients. Transplant-specific complications, there's risks involved with their immunosuppression. They do develop opportunistic infections on occasion, and they can develop recurrent disease. Whatever the primary disease that damaged their organ can come back. There's various other complications that are specific to the organ that was transplanted. Now, what about outcomes? This is a survival curve. You can see that in the first year, there's significant risk of mortality from various organ transplants. Lung is the highest risk, but the others are somewhere in here. A lot of these tend to plateau out, but not completely. You still have attrition related to complications of the transplant, normal age-related comorbidities, et cetera. So generally, For liver, the 1-year survival is about 90%. Question, go ahead. Do you have a question? Focusing, okay. All right. So usually what I tell people is that for kidney transplant, the complications of the surgery are relatively minor. So a lot of that survival drop-off that you see is related to comorbidities. For heart and for liver, usually if they make it through the first year, they're probably going to do okay, is what we tell them. But this just highlights if you don't need a transplant, you shouldn't get one. It's really only if you're at high risk of dying of organ failure. Now, what about frequency and outcomes and cost effectiveness? People, I initially was reluctant to go into transplantation medicine because, I did work in Africa and other places, and I would see that for the cost of a transplant, we could be providing clean water to all these people. And is this really justified, that what we're doing here? So, that's still something to be cognizant of, and we try to be cost effective. It turns out that kidney transplant, which is the most common transplant in the US, is actually cost saving to society because dialysis is expensive. So that's a no-brainer. We should do as many kidney transplants as possible. Liver transplants and other organs, they are cost effective according to most thresholds for cost effectiveness. So generally $50,000 to $100,000 per quality adjusted life year. But they're still a costly therapy, and that's, again, part of why, in addition to the shortage of organs, we try to reserve them for people that are not going to die of some other disease in a year or two. Lastly, I just want to highlight on one current controversy that you may have heard of in the news, and that relates to the arbitrary geographic distribution of organs that I mentioned earlier. Again, this just map shows all the different organ procurement organizations, and this map was just divided fairly arbitrarily at some point in the past, and so it's kind of a historical accident that it's broken up this way. And so there's variability in organ availability, and as such, for example, in liver transplant, the MELD score at transplant ranges from 20 in some areas to 35, the median MELD. So that means in some areas of the country, people can get transplanted with a MELD score of 20, and with a MELD score of 20, your risk of dying of liver failure is relatively low. We're talking 10, 15% in 1 year. Whereas with the MELD score of 35, your risk of dying of liver failure is nearly 100% in 1 year. So this has prompted a group of patients to get together and actually file a lawsuit against the OPTN and UNOS, and that's currently being worked out, and that's driving a lot of current changes in organ distribution, and it's likely that the current system will be changed to a system whereby organs are allocated according to the distance from the donor hospital, and so that'll partially mitigate this variability in organ shortage across the country. All right, so there's just some references, and now we'll do the post test again. Okay. Okay, so full screen. All right, so it's now active. So first question, remember, what is one indication for liver transplantation? Cirrhosis, model for end-stage liver disease score less than 15, model for end-stage liver disease score greater than 15, or metastatic liver cancer. So it looks like people are going with C, and that's correct. So just having cirrhosis is not an indication for transplant. And I brought this up because it's a common misconception. I often get referrals and patients say, well, I was told I have cirrhosis, this means I'm going to die. And no, cirrhosis, the survival for cirrhosis, if it's compensated, so no ascites, encephalopathy, variceal bleeding, can be quite good. So just having cirrhosis doesn't mean you need a transplant. So the model for end-stage liver disease score greater than 15 is usually the cutoff for saying, okay, you probably need to talk about getting them on the transplant list. And remember, metastatic liver cancer, if it's outside the liver, then replacing the liver is not going to help All right, so what is one indication for heart transplant? We've got congestive heart failure, New York Heart Association class 3 or 4 heart failure, cardiomegaly, or myocardial infarction. So good, looks like people are choosing New York Heart Association class 3 or 4 heart failure. So it's not enough to just have CHF, you have to have severe heart failure. What is the strongest predictor of alcohol recidivism post-transplant? So is it prior negative social or health consequences from drinking, duration of sobriety, type of alcohol, or friends that drink? So like most good board questions, these are all predictors of alcohol recidivism, but the question is, what is the best? So, classic board question, right? So you're correct, it's A. So all these things do predict recidivism post-liver transplant, but the strongest predictor is prior negative social or health consequences. So this is important when I get calls all the time for referrals, inpatient referrals. Patients quit drinking a month ago, family's really pushing for transplant, and I'm trying to decide, should we bring them to Loma Linda to get them evaluated or not. Over the phone is sometimes hard. What I've taken to doing is sometimes ask the referring physician to have the social worker evaluate the patient and call me. The social workers get a really detailed social history, and then I'm looking for this first thing mainly. If it's only been a couple months of sobriety, that doesn't necessarily mean they're not a candidate. If they never had any negative prior consequences and they've got good insight, they're willing to quit. What determines priority for liver transplantation? Is it social status? Is it wealth, duration of time on the waiting list, or severity of liver disease? So we've got some cynics. The only way that I'm aware that socioeconomic status can help someone get a transplant is by multi-listing. You're familiar with Steve Jobs. He got a transplant in Tennessee. And it wasn't that he bought it or anything. He just had a private jet, and he could go get on the transplant list at a bunch of places. And then when they called and they said he had an organ, he could just fly there immediately and be there. So,
the question could go the other direction.
What's that?
Social status would be negative.
Well, I hope not. If we're doing our job correctly, we don't judge their social status. We judge the likelihood they are to be a good steward of a scarce societal resource. So they could be a bum on the street, but if their family is willing to take them in and they're willing to, so yeah. But I follow. All right. What is one way of getting a transplant sooner? Pay someone off, agree to be a donor yourself, argue with your transplant surgeon. It's definitely not something I recommend. Multi-listing at centers with better organ availability. All right. Excellent. So thank you very much, and I think we'll open it up to some questions now. Question?
Hi, I have an uncle who is from the Philippines, and he came to the States. He overstayed his visa. He has type 2 diabetes, and he went into end-stage renal disease.
Mm-hmm.
And so now he's been frequenting the emergency room to get his dialysis, usually about twice a week, which is, very expensive for society. What are the chances that he gets a kidney transplant? He's in Florida.
Yeah, excellent question. We just actually had an immigration lawyer come and speak to us about this recently because we encounter this a fair amount. So what do we do with people who are not in the country legally? So the first thing is we will often get patients that come and they have insurance. They have IHP. And it turns out we do some digging and we say, you're not in the country illegally. How did you get IHP? Well, they got it fraudulently. They bought a Social Security card on the black market. This is very common. So from a legal liability standpoint and a regulatory liability standpoint, we cannot be party to fraud. So if we found out that they do that, this is not necessarily your situation, but I'm just talking about the various scenarios that occur. So then we'll rule them out. But as long as that's not the case, the next question is, do they have insurance? Are they likely to keep that insurance for preferably 3 years after transplant, but at least a year? And do they have social support? Are they going to be in the U.S.? Are we going to transplant them and then a month later they're going to? So oftentimes they have what's called PRUCAL, which is emergency Medicaid. And essentially once their emergency situation, meaning their organ failure, ends, then they lose it. And they'll be uninsured. They won't be able to afford their medications. And so if your uncle can get insurance through a family member here, and then there's various avenues with immigration attorneys to apply to stay longer. Then as long as the immigration attorney says, yeah, we've got a pretty good chance of not being deported, picked up by ICE, and the person has insurance that's likely to stay with them for the next 2-3 years, preferably, then sure, we don't discriminate against people who are here illegally. That's not our job. But we do have to make sure that they're going to have insurance, they're going to stick around, we're going to be able to make sure that we help them take care of their organ.
Wave it. I was recently in San Francisco and saw a group of Chinese people who are protesting what is being done in China. Their particular people group is gathered into concentration camps. They know the blood type, everything they need. When they need to get a cornea, they'll go in there and take corneas. When they need livers, when they need kidneys, they are taken. And the Saudis are coming and other people are coming for transplants there. They claim that those illicit transplants are being brought here to the States. Are you aware of a black market in it?
So in China, for years, there's been a problem primarily with executed prisoners. They would have a special ambulance that would go back up to the prison. They would have the condemned prisoner come out into the ambulance, shoot them in the head, load them into the ambulance, and immediately start procuring their organs. And so the international transplant community got together and had a meeting in Istanbul, Istanbul Accords, that essentially condemned this practice. And most of the journals will make people certify that their research paper they're trying to publish was not using prisoners that were executed. But the funny thing is the Chinese government every couple of years says, okay, that's it, we're not using organs from executed prisoners anymore. And then 2 years later they'll say, okay, we're not doing it anymore. So as far as the concentration camp and bringing these organs over here, I don't really see that possibly being happening because there'd be too much ischemia time to get them over here. So people from wealthy countries will sometimes fly to other countries to get living donor transplants. And there's been one reported case even of someone in Canada who flew over somewhere, paid for a living donor transplant, came back to Canada, wasn't feeling so hot, went to the doctor, had a scan, there's no kidney in there. Just cut them open, sewed them up, So transplant tourism is a big issue. So, okay, sorry, which one do I do first?
Here first.
Would you comment on the relative incidence of liver failure due to hepatic steatosis or fatty liver versus hep C versus cirrhosis? And is there utility in treating the steatosis, fatty liver with pioglitazone?
Yeah, sure. So fatty liver is a rising cause of, still not as common indication for transplant as alcoholism and hep C, but we expect that it will be the #1 indication very soon. As far as pioglitazone, there's one study that showed a benefit, but it was short term. And the problem is long-term, what does pioglitazone do? It generally causes weight gain. So there was a follow-up to that study showed that the curves between the two groups in terms of their amount of fibrosis in the liver started to come back together, and that's probably why. So it's not yet recommended as standard of care.
I hear in the news occasionally about advancing technology of 3D printing organs, like with a scaffold and then putting in cells. Is that too far down, or have you heard anything about that as for a novel source for organs?
Yeah, so people have been asking me about this for years, and what I would usually say in the past is, well, we can grow the cells in a dish, but it's like saying, okay, I've got all the building blocks for a house, I'm going to pile them in a pile. That's not a house, right? They have to be organized in a very specific orientation. So I think 3D printing has a lot of potential for that. Like you said, having the scaffolding and then trying to getting all this proper cells in the right place, and so it's still at least a decade away, but I think that could happen.
I'm curious, which type of alcoholic beverage indicates a higher risk of recidivism?
Yeah. Hard liquor, generally, just because it's easier to drink more that way, and people that are hard liquor favorers tend to just more easily get drunk.
What would you recommend for a faith-based institution like Loma Linda to become a moral voice to these other countries that are doing abominable things in transplantation, and to become again the head and not the tail?
Yeah. Well, I think that's hard. I think I don't want to point fingers too much at other countries. I think they have social circumstances that we can't begin to comprehend sometimes. So, yeah, I don't know a good solution to your question. I think we, as a group, are participating in societies that have things like the Istanbul Accords, and continuing to support that and further that.
How close are we to porcine xenografts for livers? I wanted to.
I don't think that we'll be. So, good question at Loma Linda. You were all familiar with the history here, baby Faye, but I don't think that we're going to be using xenografts anytime soon. There's still lots of concerns about zoonotic infections, things like that. So.
Well, with that, thank you, Dr. Volk, for your presentation.